Welcome to another video of surgical ICU discussion. Here we shall discuss about venous thromboembolism in all its aspects. The statistics presented here will show you that 1 out of every 10 deaths in the hospital occur because a venous thromboembolism has progressed to PE, and pulmonary embolism is seen in 1/3 patients who have had an autopsy. 1/3 of the emboli are the direct cause of death, and trauma victims have a 50% chance of venous thromboembolism in the first week. So these statistics are scary enough. The risk factors for developing a VTE are major surgery, trauma, malignancy, and acute medical illnesses. The patient-specific factors are a history of thromboembolism, obesity, being more than 40 years of age, and having a hypercoagulable state. Now, nobody will come to you as a trauma patient saying that I'm having a history of thromboembolism. It is up to you to start the prophylaxis as soon as possible, but provided that the patient's condition permits you to do so safely. The ICU-related factors are mechanical ventilation, neuromuscular paralysis, central venous catheters, sepsis, coagulopathy, and heparin-induced thrombocytopenia, the mechanism of which we shall see later. So all these ICU-related factors either reduce the flow or they increase the risk of coagulopathy. As far as the prophylaxis of VTE is concerned, those patients less than 40 years of age and undergoing minor surgery should be mobilized as soon as possible, at the earliest. Those who are less than 40 having no risk factors and undergoing major surgery, which means that they have to be operated for more than half an hour, should ideally be given either heparin 5000 units twice a day or clexane 40 mg once a day subcutaneously. Ideally, the dose of both of these is 2 hours before surgery. For major surgery, for those who are more than 40 and those having risk factors, the risk is high. Therefore, either heparin thrice a day or clexane 30 mg twice a day. Again, the first dose being 2 hours prior to surgery. For those who have the highest risk of VTE, they should be given the same dose of heparin or clexane, in addition to which they should also have a mechanical compression device. On comparing the various methods, a pneumatic compression device is more superior than a graded compression stocking, and the pressures that they generate at the ankle and the thigh are shown. A low molecular weight heparin is better than heparin because heparin does not provide an optimal prophylaxis for spinal cord injuries and trauma cases. And one should remember to continue the prophylaxis for 28 to 35 days, that is 4 to 5 weeks, after any major orthopedic surgery or trauma. Antithrombin 3 is a protease which lyses thrombin and activated factor 10. Heparin binds to antithrombin 3, forming a complex, which then further inactivates several coagulation factors such as 2, 9, 10, and 11. Inactivation of factor 2A occurs at doses far below those needed to inactivate the other coagulation factors, which means that a low dose of heparin can actually inhibit thrombus formation without producing full anticoagulation. Now, the complex of heparin and antithrombin 3 also binds calcium, that is factor 4, and some patients develop a heparin-induced antibody reaction which cross-reacts with the platelets binding site, causing platelet clumping and thrombocytopenia. Ideally, one should start low-dose heparin 2 hours prior to surgery and continue to up to 7 days or till the patient starts ambulating. The smallest molecules of heparin, also known as low molecular weight heparin, it makes sense. These are more potent and have more uniform anticoagulant properties. They require less frequent dosing, and there is no need of monitoring with a full anticoagulant dosing. Usually these are given 2 hours prior to surgery, but for orthopedic procedures they are given about 12 to 24 hours prior to surgery. But this has a risk that it might increase the bleeding. Therefore, pre-operative dosing may be abandoned in favor of starting the dose 6 hours post-op. If one waits longer, the efficacy is reduced. Therefore, in orthopedic procedures, it is better to start LMWH 6 hours post-op. With spinal anesthesia, there is an increased risk of spinal hematoma and paralysis. Also, one should note that low molecular weight heparin is excreted by the kidneys, thus give a 40 mg once a daily dose in renal failure cases. Warfarin is a vitamin K antagonist, which then prevents the gamma carboxylation of coagulant factors 2, 7, 9 and 10. It takes around 3 to 5 days to start acting, and in stopping the treatment, it takes around 3 to 5 days for the coagulation to normalize. The disadvantages of warfarin is that it can have a multitude of drug interactions. One should closely monitor the patient for these. It's difficult to adjust the dose, and there is a delayed onset of action. Usually you start with a 10 mg evening dose before surgery and give a daily dose of 2.5 mg to achieve a PT with an INR 2 to 3 times of normal. It takes up to 3 days for warfarin to have its complete effect. As explained earlier, antithrombin 3, it lyses thrombin and inactivates the factor 10A, whereas fondaparinux selectively inhibits factor 10A. Just like heparin, it binds to antithrombin 3, but then it selectively inhibits only factor 10A. Thus, there is no need of constant lab monitoring, and again, there is no heparin-induced thrombocytopenia. The dose is 2.5 mg subcutaneous every day. It's excreted by the kidney, thus it's contraindicated in renal impairment, and also contraindicated in those patients who are less than 50 kilograms in weight. During the coagulation process, the fibrin monomers get linked to form dimers, 2 molecules. Now, when the clot gets lysed, the amount of D-dimer in the blood will start increasing. The D-dimer values can be increased in sepsis, malignancy, pregnancy, heart failure, renal failure, and also in advanced stage. Up to 80% of ICU patients have an increased D-dimer value in the absence of venous thromboembolism. Therefore, there is no clear clinical or lab finding to confirm or exclude pulmonary embolism. As you can see here, 40% of patients have dyspnea, 47% have tachycardia, 50% have tachypnea, 40% have pleuritic chest pain, 30% have hemoptysis, another 30 may have hypoxemia. So there is no clear-cut way to confirm or refute a diagnosis clinically. The D-dimer value can be used mainly to exclude a diagnosis of VTE. A diagnosis of venous thromboembolism and at the same time pulmonary embolism can be started by a duplay of the femoral veins with compression. The veins which are incompressible give an indirect evidence of VTE. Duplay of the veins below the knee joint can actually miss DVT in 2/3 of cases. Therefore, it's advisable either to do a contrast venography or to do multiple studies. Radionuclide lung scan and pulmonary angiography test the ventilation perfusion, which again are an evidence of pulmonary embolism. A spiral CT is done with a contrast injection, and one has to hold the breath for 30 seconds to complete the scan. It's a good way to exclude pulmonary embolism, but again it's not so suitable for ventilated patients. The treatment for a non-life-threatening pulmonary embolism is a heparin infusion. Usually 20,000 units of heparin are added to 50 ml of saline, and a bolus dose of 80 international units per kg is followed by 18 international units per kg per hour. The PTT is checked after 6 hours and the dose is adjusted to get a PTT of 46 to 70. One needs to increase or decrease by 4 international units per kg per hour to titrate the target PTT level. Or one can even give low molecular weight heparin 1 mg per hour subcutaneously every 12 hours. The advantage of LMWH is that it doesn't need monitoring. One may start warfarin on day 1 and stop heparin once the INR is 2 to 3 times that of normal, and one would continue warfarin for 3 months. Now, how long would you go on with full heparinization? It depends, either 5 days or 10 days. For a life-threatening case of pulmonary embolism, one needs to go in for thrombolysis, either with alteplase or retaplase. There is a 12% risk of major bleeding and 1% risk of intracranial bleeding. One has to view the risks and benefits before starting the therapy. Another method is using an IVC filter if the thrombus is there in the deep veins below the lower limbs. Thanks for watching. Like, comment, subscribe, email me.